Thanks, Joshua. It's a pleasure to have everyone here as well. Thank you all for joining us. Today's session, as Josh mentioned, is about the difficult conversations that we have with people who are living with dementia and as caregivers. And so let's look at our learning objectives to begin. By the end of the session, what I'm hoping that each of you will take away is a recognition of how anticipatory and ongoing grief can influence caregivers, the family relationships, and difficult conversations throughout the dementia journey. As well, um, you'll be able to describe how dementia-related changes may affect communication, insight, participation, and decision-making. You'll be able to appreciate and use a person-centered palliative approach to balance safety and independence with both dignity, comfort, as well as connection, and what matters most to the person who is living with dementia. And then finally, we'll be applying the practical communication strategies to conversations about accepting support, safety at home, care transitions, advanced care planning, and end-of-life wishes. So today's session, we're going to start by looking at what anticipatory grief is in dementia, as grief in dementia often begins long before death, and families may grieve changes in memory, personality, roles, independence, shared routines, future plans, and the relationship as it once was. So some of the things that grief in dementia may include are grieving the person as they are changing while still loving the person who is here. And so that can include, again, the memory, personality, different roles. At one point, the person who you are caring for may have been able to do the yard work, and now you're responsible for that. And the person may have been able to express how much they loved you, and now they aren't able to express that, even though you know that love is still there. Grief and dementia may also include a loss of shared memories, routines, roles, and future expectations. Repeated small losses over time. Ambiguous loss, which is the person is physically present, so they will be sitting in front of you, but aspects of the relationship will feel changed. And anticipatory grief, which is what we're trying to understand, is that grief begins well before the end of life. Normalizing grief as a natural response to change is not a sign that someone is coping poorly. Caregivers may feel guilty for grieving while their loved one is still living. But if we reframe this, grief often reflects attachment, love, and the emotional weight of witnessing change. So grief in dementia is not a single event. It can be a series of losses that unfold over time, and caregivers may need support at each stage, not only near the end. That would be our definition of anticipatory grief. Next, we look at how grief impacts communication and decision-making. So grief can make decisions feel much heavier. It may affect how families hear information, respond to risk, make plans, or cause disagreements with each other. Grief can show up as avoidance. An example of this could be, we are not ready to talk about that yet. Or urgency, we need to fix this right now. Conflict, family members coping differently. Grief affects everyone differently, and so some family members may want to be making decisions quickly, while others say, let's just wait and see, or this is just dad being dad. Guilt. Am I taking away their independence? Fear. What if something happens? And overwhelm. Overwhelm can be difficulty absorbing all of the information, making the decisions, finding the resources, bringing it all together in order to create a support system. The goal in decision making is not to remove every risk for your loved one or for the person who's living with dementia. It is to support them to live as safely, meaningfully, and as independently as possible. Families may not be disagreeing only about practical issues. They may also be grieving different losses at different times. So while one person is focused on safety, another may be focused on independence, and another may still be struggling to accept the diagnosis or the disease progression itself. So before asking, what decision needs to be made? It can help to ask, what loss is this decision asking the family to face? Difficult conversations are about more than the decision. They often involve grief about changing abilities and roles, fear of what may happen next, tension between safety and independence, guilt about taking over decisions from someone who used to be capable of making all of these decisions on their own, or at some point may have even made decisions for you if they're your parent. Different opinions among family members also can create very difficult conversations, and uncertainty about what the person living with dementia would want. A compassionate approach to difficult conversations asks, what matters most to the person living with dementia? What loss is this decision asking us to face? How can we preserve dignity, choice, connection, and quality of life? What is the least restrictive and most supportive option? The goal is not to remove every risk. It is to support the person to live as safely, meaningfully, and independently as possible. And a palliative approach places the person and family at the center and asks what matters most to them. It considers physical, emotional, social, practical, cultural, and their spiritual needs, not only the disease or the immediate risk. Keeping the person at the center of decisions. This is key. So when facing a difficult decision, consider, who is the person beyond dementia? What matters most to them right now? What might be gained or lost with each choice made? How can dignity and connection be protected? What option is least restrictive? How can the person remain involved? And what support do their caregivers, family, and friends need? A person-centered and palliative approach to dementia care is not limited to the final days of life. In dementia care, it can begin early by focusing on comfort and dignity, quality of life, relationships, values, and what matters most. But dementia care should not be reduced to risk management. Safety does matter, most definitely, but so do identity, belonging, purpose, culture, relationships, and meaningful moments. The goal is not, again, to keep someone safe. It's to support a life with as much dignity, comfort, connection, and meaning as possible. You're going to hear me say that a few more times. Common difficult conversations and decisions. Difficult conversations are often difficult because they touch identity, freedom, fear, grief, and love. The goal is not to win a conversation. The goal is to preserve trust while moving toward a safer, value-aligned care. Many of these difficult conversations and decisions that are made around safety, independence, care transitions, and end-of-life wishes. For example, driving and transportation. It's well known in the dementia community that a lot of our elderly will avoid going to the doctor, especially if they suspect that there may be some sort of cognitive decline because they're scared to give up their driver's license. And so this can definitely be a safety concern. This is one of those difficult conversations that can come up between a doctor and a patient, a son and a father, a child and a mother, a spouse. It's siblings. This is a really difficult conversation. This feels like independence has been taken away. Medication safety, living alone or home safety, accepting help in the home. Those are another two big aspects that are scary conversations for people to have. Personal care and hygiene, financial and legal planning, moving to assisted or long-term care, and advanced care planning and end-of-life wishes. These conversations may happen gradually. They don't all happen at once. Caregivers may need to revisit the same issue multiple times as dementia progresses. It is best that families start these conversations before a crisis, whenever possible. It's important to lead with values before logistics in each of these conversations. For example, instead of starting with, "You can't drive anymore," try saying something like, "I know being independent has always been important to you. I want to talk about how we can keep you connected and safe while also respecting that independence as much as possible." A compassionate communication framework. So person-centered communication recognizes an individual's unique identity, history, abilities, and values. Communication remains possible throughout the dementia journey, although how the person communicates may change. To communicate compassionately with a person living with dementia, first we must prepare. We'll choose a calm time, familiar setting, limit distractions and unnecessary participants. You can decide on one main concern to address, allow enough time to address that concern, and consider any hearing, vision, language, and cultural needs. Connect. Then we begin with reassurance and respect. We'll sit at eye level and use the person's preferred name. Although it always seems nice to say sweetheart, lovey, dear, when we're having an important conversation, it's usually best to use a person's preferred name. It shows a different level of respect. Acknowledge the importance of the relationship, starting with a phrase such as, "We've been through a lot together. You know how much I love you." Phrases such as that. Ask. Ask permission to discuss the concern. Invite the person's understanding and perspective. Use open questions when possible. Listen. Allow extra time for responses. Listen for feelings and values, not only for facts. Do not interrupt or repeatedly correct. And notice any nonverbal communication. And respond. Name and validate the emotion. I can see you're feeling very frustrated. Use short, clear language. Offer limited, meaningful choices. And summarize one agreed next step. So if you were looking at driving, for example, then summarizing one agreed next step could be, why don't we make an appointment to go see your doctor and see what they think? Practical language that reduces defensiveness. Use observations. So instead of saying, you are not safe at home, by using an observation, you may say, I noticed the stove was left on twice this week, and I am worried someone could get hurt. Using we language. Instead of you need help, you could try using the sentence, how can we make this easier and safer together? Validate before problem solving. I can see this feels upsetting. Or another example could be, it makes sense that you would be worried about losing your independence. Connect the change to a value. Because staying at home matters to you, let's look at supports that may help you remain there. So the value is staying at home, not wanting to transition into care. And so connecting a change in order to make that happen would be looking at supports that can help that value remain as is. Offering manageable choices. Would you prefer someone to visit in the morning or the afternoon? Allowing pauses. Silence always gives a person time to process and respond. And you'll notice as dementia progresses that the pauses will need to be a little bit longer. And it's hard as a caregiver or as a support to sit comfortably in those pauses, but it's very important. This allows dignity and person-centered communication to allow for the person living with dementia that time to process the information that was provided and then respond appropriately as they see fit. And so what we may view as an uncomfortable pause in a conversation is just time for us to sit and wait. We don't need to keep repeating. We just sit quietly and wait, although it feels uncomfortable. And then finally, we close with reassurance. We do not have to solve everything today. And that's always a very reassuring statement. So after a very difficult conversation, something that can reduce defensiveness in a person who is living with any form of a cognitive decline, dementia, is to say, we don't have to solve everything today. We've had a good conversation, thank you. And just giving them that reassurance that everything is going to be okay. So an example of a difficult conversation using everything that we've discussed so far, a person-centered palliative compassionate approach while reducing defensiveness. We're going to look at an example of accepting help to remain at home. So the goal is to support the person's wish to remain at home while introducing help in a respectful way. First, we'll start with empathy. I know how important it is for you to remain in your home. Then we name the concern gently. I've noticed that some daily tasks have become more tiring lately. Connect the support to what matters. A little help may make it easier for you to stay at home safely and comfortably. Offer meaningful choices. Would you prefer help once or twice a week? And in the morning or afternoon? Now, you would want to break these up. So you ask the first one, would you prefer help once or twice a week? And once that's answered, then you could ask, and do you prefer that in the morning or the afternoon? Avoid arguing. We may see things differently, but I want us to find a plan that feels right for you. You've probably heard that with dementia, you will not win the argument. You need to live through their eyes. So you are living in their shoes in that moment. They cannot view things the way that you're viewing things, but you can transition the way that you're viewing things into how they may be seeing things. And so if you are with a person who is living with dementia and they are currently not living in the present, and so they've gone back to, we'll say, their 50s, and they have a child that is still living at home, then that's where you need to be. So if their response to getting help in the home is, well, we already have Joe here and he can help with the yard work, and he can say, you know what, I think we can find a plan that would feel right for you, rather than saying Joe doesn't live here anymore, because that is not going to help with the discussion that you're currently having. Keep it simple. Someone could help with meals, laundry, and other tasks. And always return to reassurance. You are not facing this alone. We will make these decisions together. We don't have to solve everything today. This has been a great discussion. Some scripts for common difficult conversations that you may encounter. When a person living with dementia says, there is nothing wrong with me, a good response to this could be, you may not see it the same way I do. I would still like us to talk about what I've noticed and find a plan that feels respectful and comfortable for you. Or if they refuse help, you could possibly suggest that I hear you do not want someone taking over. What kind of help would feel least intrusive to you? When a caregiver feels guilty, you could say, needing more support doesn't mean you've stopped loving or caring for them. It means that the care needs have just grown beyond what one person can provide. And so there's no reason for the guilt. When a family member disagrees, or when family members disagree with each other about the care for a loved one living with dementia, a good script would be that we may be reacting differently because we are each experiencing this loss differently. Can we return to what matters most to our loved one who is living with dementia? And when no option feels ideal, there may not be a perfect choice. Let's identify the option that best protects dignity, comfort, safety, and connection. when the conversation becomes overwhelming. This is a lot to take in. Let's pause and return to it when we have had time to think. And when the person repeatedly asks the same question, this is common. And a nice response to this is, "You are safe. I am here with you. We will work through this together." And you can take any pieces of those. Any form of reassurance is typically the best. Talking early about what matters most. Support, planning, and conversation can reduce crisis-driven decisions and help families feel more prepared. Begin early in the diagnosis while the person can still share. So, what makes life meaningful to them? What comfort, dignity, and quality of life mean to them? We want to be sure that they're able to still share that. We also want to make sure that they can still share the important abilities and routines and relationships and traditions, hopes, fears, worries about the future, cultural, spiritual, and personal wishes, where and with whom they would prefer to receive care, and who they trust to speak for them if they cannot speak for themselves. Talk early about values, wishes, and what matters most. Create or revisit advanced care planning documents. Identify a substitute decision maker. These are all very important to talk about early in a diagnosis. Ask healthcare providers about changes in safety, care needs, and comfort. Connect with caregiver support groups. Use dementia-specific community resources. Build a circle of support before crisis. And revisit plans as the dementia progresses. When talking about what matters most, always consider, what is one important conversation I need to begin? And how can I begin this conversation gently, imperfectly, and with compassion? You want to remember that caregivers do not need to have perfect words. They need support, courage, and a values-based approach. They take one small step, and do not feel that you need to solve everything at once. Difficult conversations in dementia care are not only about loss. They are also acts of love. So when we approach them with compassion and respect, we help protect dignity, we reduce crisis, and we honor the person, not only the disease. When a person can no longer clearly express their wishes, we want to continue to include them through simple language and manageable choices, extra time to respond, which is those long, uncomfortable pauses, attention to facial expressions, behavior, comfort, and distress, familiar routines, people, objects, music, and surroundings. We want to let what is known about the person guide decisions. So previously expressed wishes are very important. Lifelong values and beliefs, culture and spiritual traditions, important relationships, familiar routines and roles, and sources of comfort, joy, calm, and meaning. The question is not, what do I want for this person in my life? It is, knowing them as I do, what would they want me to consider? What would they want us to consider? What choice best honors who they are? There may not be a perfect or painless decision. Families may experience guilt, even when they are acting compassionately and following the person's wishes. Substitute decision makers, they require clear information, time to ask questions, and emotional support. For clinicians or facilitators who are working with families who, or with caregivers or people who are living with dementia, some helpful language examples are tell me what they were like before dementia and what mattered most to them. Or what do you think they would say about this decision? Another option is let's consider both what this treatment may achieve and what it may ask them to endure. And I guess a final option could also be based on what you have told us, which option seems most consistent with their values? So the goal, as I've said, you're going to hear it a few times, is not only to keep someone safe. The goal is to support a life with as much dignity, comfort, connection, and meaning as possible. Dementia care includes loss, but it also includes relationship, meaning, creativity, and moments of incredible connection. A dementia-friendly approach does not deny grief. It makes room for grief while still looking for life and joy and belonging. Even when abilities change, personhood remains. Even when conversations change, connection is still possible. We may not always be able to make a difficult decision feel easy, but we can help the person feel heard, respected, supported, and loved. Difficult conversations and decisions in dementia care are acts of love. When we approach them with compassion, clarity, and respect, and seek to protect both safety and dignity, we help the person feel heard, supported, and valued throughout their dementia journey. For more information, you're more than welcome to contact the BC Dementia Care Society. You can reach us via email at info@bcdementiacare.org, by phone 778-888-7445, or you can check out our website at bcdementiacare.org. Thank you so much for your time. I am going to stop sharing my screen.
That is amazing. Thank you, Krista, so much for that presentation. And so I'd like to
Thank
open
you.
up a time for questions. And so if you have any questions or comments, feel free to put them in the chat or raise your hand and we can ask Krista. The one question I have as people sort of think about is, can we know more about the BC Dementia Care Society? Like what you do, why you started it, why you founded it? I think it's just an amazing place that you have, really saw a gap in. And so if you could, share a little bit more about that and what people can expect for people in your programs.
Definitely. So the BC Dementia Care Society was founded 4 years ago, and it was to just fill gaps. There's a lot of social programming that exists, and the Alzheimer's Society of BC does a wonderful job. Family Caregivers of BC. There's the palliative support. There's so many wonderful programs out there, and we just wanted to be on the ground providing dementia specific supports where we could, where we were seeing gaps. And so I founded the society in order to provide more connection. And I wanted to be able to provide connection between caregivers and people living with dementia, and to be able to find that joy, those moments, the sparkles, the laughter, the tears, the any form of connection that makes it not feel as much like a caregiving journey, but still a relationship between a child and a parent, a relationship between spouses, a relationship between siblings. And so we try to provide different ideas and programs. We have Memory Cafe, which brings caregivers together with their loved one living with dementia. And we do a lot of fun activities that can all be integrated back into the home. And so when someone finds something that works in our program for them, they can take it home so easily. And they also build social connection within the community with other caregivers and people living with dementia and create these friendship circles outside of our programming that they walk away with in our communities. And it's been a great support to all of them. We also have caregiver support groups, and we provide, we have an advisory council for lived experience for people who are living with dementia as well as their caregivers. And we have dementia specific resource guides. There's we're building from the bottom up and trying to create dementia friendly community, acceptance, understanding, and joy, and bringing the personhood back into what dementia is and the understanding.
That's
Does that
amazing.
answer your question, Joshua?
Yes, it does. Yes. And so we have a few questions in the chat. So one
Okay.
says, from your experience, are there cultural or racial differences in the way caregivers respond to dementia in a loved one?
So is this in terms of in the family caregivers or in a care setting? I'll say within the family, yes. Okay. So within the family, it's interesting because there are some cultures who deny the fact that dementia exists. And so it doesn't mean that they're not caring for their loved one. It means that they care for them differently. And and it's not bad, it's different. But there are some cultures that also believe that dementia not too long ago was actually almost a witchcraft type scenario. I don't know how to describe that exactly, but where people became evil if they developed dementia. We don't see much of that now. I have had to have a couple of conversations around that to explain that they are not a bad person and that this can happen to anyone. But for the most part, we find that there are other cultures who their families are, the whole extended family comes together and loves on that person unconditionally. And it's, there's, without like, we have the Eastern Asian cultures are very family oriented. The Portuguese cultures, the Spanish cultures, very family oriented. So they really come together and just envelop and embrace and work together to support the caregiver and the person living with dementia. And that's not to say that other cultures don't, because there are a lot. And then in Canada, it's so diverse. And so, what we love about the programming that the Alzheimer's Society is providing and other programs are providing, and even the caregiver support groups, is that everyone can see how others are working with their loved one with dementia, and that we can not break cultural barriers, but bring them together so that we're learning from each other. Does that answer your question, or was that really vague because I didn't want to bring up one culture versus another?
I think it was good. I think that there wasn't too
Okay.
specific in the actual comment. Another comment is, how do you differentiate between dementia and memory loss?
Okay. So dementia is an umbrella term. And so we'll start with that. So dementia is an umbrella term, and it has a number of different forms of dementia, like I'm going to break it down into common language. It's an umbrella. Underneath that umbrella, we have Alzheimer's, frontal lobe, frontotemporal lobe, we have Lewy body, we have all these different forms of dementias that fall under that. There's 60 or more of them, but those are some of the most common one, Alzheimer's being the most common. Um, and so we have with those dementias, it's not just memory loss. You start to lose the ability to um, function properly. Different things will start to go, whether it be you're hearing things like there's more of an echo in your head. There's your vision is not cooperating properly. Things just don't seem to work together well. And then your body will slowly start to fail you because you're not learning new things. You cannot learn new things. You can keep the skills that you have. And so that is a dementia. Memory loss can be a cognitive decline that can happen at any age, where dementia is getting younger and younger and younger as well. Um, but a memory loss is specifically memory loss. And so you would just be looking at having concerns with, where did I put my keys? Or, oh, I forgot to go to this appointment today. Or, did I take my pills? Things like that. Or did I turn off the coffee pot when I left today? But dementia is repeated memory concerns along with some of these other things that will progress. And so the only time you need to really become concerned about a dementia beyond a basic memory loss is when you start to see things such as not forgetting where you put your keys, but putting your keys in the freezer and putting things in different places where they're not going to be found, or starting to hide things, or getting lost on your way home. And not because you're distracted one day and you're on the phone and you're doing something else and drinking coffee and you missed a turn, but getting lost on your way home and not being able to find your way back, or going for a walk and not knowing where you are. Those are then the red flags for a concern versus just memory loss.
Okay, that's great. Thank you. Another question is there any special training that can make someone a dementia care or caregiver specialist as an FM doctor?
As a family medicine doctor, there is. So there's some different dementia certification programs. Um, Actually, what I could do is I could respond to that one too by email. If you wanted to put your email into the chat, that would be great because I could send you some of the specific ones around that. But there's master's programs that are specific towards family medicine, as well as just some 12-week certifications, but nothing. I don't know of any that are specific only to a family doctor in BC. I would have to look into that, but I do have a number of other programs that, depending on whether you want to commit 12 weeks or 2 years to the program, that would be definitely worth considering. Because I would love to have our family physicians more involved in the diagnosis and in the understanding of dementia. We don't have enough gerontologists in our province, and we are going to lose the battle. It's hard to be making those referrals all the time. And so family doctors they're our lifeline.
Okay, that's great. And so another question, do you offer presentations to long-term care homes for families similar to this one?
Yes. Yes, we do.
Okay.
Yes. Yeah, you can reach out.
Excellent. Another comment, I am new to the province, but not new to the population. Social worker who works with people with dementia and their caregivers. So this is a refreshing presentation, so that's great. That impacted. So how do you reconcile risk and dignity and autonomy? I've worked with rural populations who want to stay at home and do become at risk of wandering in the cold, but being in a more institutional setting would create suffering. So how do you work with that?
It's so that's such a difficult balance because you have to be able to have those conversations around the importance of home safety and of ensuring that you're able to bring someone into the home and saying we want you to be able to remain at home, but what can we continue doing in order to allow this to happen? And you don't want to be presenting a long list of things, but you do want to present options and have it as a we conversation and ensuring that they are aware that safety is the biggest concern. And I, it's so, it's easy to say from the outside. And then once you're in one of these conversations, all of this kind of seems to go like, this doesn't make sense. And so the taking it one step at a time and trying to involve the family as much as possible and having the family understand that it is important to make it um, a we conversation. We want you to understand our love for you. We hope that you can see the safety concerns. What can we do to support you? What are some choice? Here's some choices. Would you prefer mornings or afternoons? And give two choices. Someone is coming in to help you. Do you prefer mornings or afternoons? They're still getting a choice, but it's not what they may want. And so I think the safety with wandering in the cold and all of these things, it's the dignity. It is. It's the safety versus dignity, but are we always safe? Really? I mean, if I hop in my car and drive to Burnaby today, is it a safe decision? I don't know. It's one of those things, right? But yet it's for me in this moment, it would be something that I may choose to do. And so I always try to determine whether if I were indignant that I am not going into long-term care, and I've said it from the day I turned 55, and then someone says, okay, well, now you have dementia. This is what you need to do. Is it? That's the question. And I think it's a respect that we would all like to be shown. And it's thinking about what the person would want. And it is a huge safety issue. And I still go back to dignity, what they would want, and how we can try to keep them as safe as possible around that.
Mhm.
That's a real roundabout answer, but I always put yourself in their shoes is always my way of trying to approach it. And it's not going to be a life well lived if we're not happy, I guess. And if we don't know what happiness is in that moment, then I guess we can start to look at other choices. But it's safety is huge, but dignity, personhood, a sense of purpose, those are all huge as well.
And I think it's great. And I think just 'cause I know more about sleepwalking and stuff, and it could be just having different safety
Yeah.
measures. Like now we have those motion censored cameras that can go off and like identify when maybe they leave their house or when they're in the kitchen and things
Yeah,
that can help you out if you are away at a distance, to help you a little bit more, I would think. So I would think technology as it improves can sort of help in
that's
different
true.
ways. also.
Well, and you can also put the little trackers in the
Oh yeah.
insoles of shoes. And
Oh, that's
then,
awesome. Yeah.
so, I mean, are they going to get up and wander at night and put their shoes on? Well, you might have to put them to bed with their shoes on. I mean, there's things like that, or put them to bed with socks on with a tracker in their socks, or like every night there's a tracker on their body somewhere just in case. And so, there's things like that that you can consider that you're right, Joshua. The technology is amazing and it can really help to preserve that dignity. Thank you. Yeah.
We have another question. Do you offer training to practitioners to facilitate and run support groups that align with the ones offered in your organization?
Yes. Yes, we do. Yeah. Yeah. You can reach out and we offer that as well.
Okay, there's a lot of email addresses and thank yous, and so this is great. We're going to have to wrap up, but I do want to sort of mention too, I'm glad you talked about advanced care planning. And we will put a link into the documents that we're sending out. We did do a talk on advanced care planning and how it can impact grief and bereavement for the individual and family and caregivers, which I think is really nice too, on like the importance of it. And when it's not done, as Krista, you would probably say, there's a lot of grief and challenges that can come about. And so how important it is to do it prior to someone having memory loss and dementia. And so thank you so much, Krista, for being here and just doing the beautiful work that you're doing within our communities. I feel that said, like you said, it's 4 years old. And I'm really happy you're really facilitating these gaps because we need people like you in the province to continue to do more and more of this work. So, thank you
Thank you.
again.
Thank
And so,
you for having me.
so we hope everyone else enjoyed the session, and we ask that you complete a short survey that will pop up when you leave this meeting. And so registration for the next session in the series is titled Honoring Grief in Long-Term Care Communities, Struggles and Strategies. And so it's scheduled for July 30th from 12 to 1:15 p.m. PST. And so you'll find the link in the chat. And to be notified of other sessions in this series, you can subscribe to our newsletter. And so our aim is really to provide you with the presentation recordings, any kind of summary notes. There was a ask for your presentation slides, if that's something that you're comfortable giving, Krista. We can do a PDF version of it. And then any other resources will be available in the next 7 working days. So just watch your email for this information, or you can also visit our website for any other upcoming ECHO sessions. So thank you again for everyone for being here, and have a great rest of the day.
Thank you, everybody.